Hi, everyone. My name is Dr. Don Buford. I'm an orthopedic surgeon based in Dallas, Texas. I am very grateful for the invitation to participate in this meeting, and I look forward to sharing some of my thoughts on how I improve rotator cuff healing both in the office and in surgery using orthobiologics. My website can be located at texasorthobiologics.com, and I look forward to further exchange of ideas with all of you. These are my disclosures. I will let you review them on your own. Just know that none of these disclosures will have a significant impact on the topic of this presentation. This is the handout for the presentation. It can be found on the internet at buford.info/EHS 2025, or you can use the QR code. So let's jump in. The first question I would have for all of us is, what if we could improve the outcomes for patients with rotator cuff pathology by manipulating the biology of healing in the office? And then the second question would be, what if the next great advancement in improving rotator cuff repair outcomes is not with better anchors or better sutures, but with harnessing the biology of healing? So to answer those questions, I would like to review the best available clinical evidence. I'm going to focus on human outcome studies using FDA regulatory compliant orthobiologics because that's what I'm forced to use in my country. As a result, I will focus on presentations and focus on publications that use platelet-rich plasma, bone marrow concentrate, and adipose tissue. I'm going to start with platelet-rich plasma. I'm going to start by focusing on the patient that comes into our clinic that has rotator cuff tendinopathy, or also called a partial tear in the rotator cuff, or they may have chronic severe impingement type symptoms with rotator cuff changes on MRI scan or on ultrasound. We have to first identify what we're going to call platelet-rich plasma, and we have to first try and come to some sort of consensus about appropriate dosing for these types of patients. There was a study published back in 2023 that looked at this exact question. What is the proper dosing of PRP for soft tissue pathology, including rotator cuff tendinopathy? What we found was in 14 out of 14 studies where the platelet dose was less than 3.5 billion platelets total, those studies showed no statistically significant improvement in clinical outcomes compared to placebo. However, in the studies that had platelet dosing above 3.5 billion platelets, 9 out of 11 studies showed statistically significant positive outcomes. And so the take-home message from this work was to get your soft tissue PRP dosing above 3.5 billion platelets. Most of the time to do that, if we don't have a hematology machine in the office, we want to draw 60 cc's of blood minimum to ensure that we get our soft tissue PRP dosing above that 3.5 billion threshold. This is an example of a dose response curve. Based on the previously mentioned publication, if we have platelet doses around 2 billion, it really didn't seem to matter how many times we injected the patient. There really wasn't any clinical benefit. However, if our doses are above 3.5 billion, and I'm about to show you some research that suggests if our doses are even higher in the 5 billion range, we can get patients higher up on this dose response curve. We can get better clinical outcomes. How do we get to 5 billion platelets clinically? It's easy if we have the ability to check because we can run the PRP through a hematology analyzer. If you don't have that luxury, then I would take these 5 steps or consider these 5 steps. Number 1, assume that your patient has the lowest normal human platelet count, which is 150. I would fill a 60 cc syringe with blood and a small amount of anticoagulant. I tend to use 6 cc's of ACDA. When you do that, the starting platelets in that syringe will be between 8 and 9 billion platelets. If you know your kit's platelet recovery percentage, then that should ensure that you're going to have at least 5 billion platelets in your end product PRP. In order to do that, for example, if you're starting with 9 billion platelets and you want to end up with 5, then you should have a kit that has a platelet recovery percentage of at least 60%. The pro tip is that if you have a kit with a platelet recovery percentage less than 60%, or if you're starting with a kit that doesn't draw 60 cc's of blood, you're going to have to use more kits, or you're going to have to draw twice as much blood, in my opinion. Pro tip number 2, if you want to be sure of getting to 10 billion platelets, which is often a number that's considered when we're treating degenerative joint disease and some of the larger joints like the knee, then you need to draw 120 cc's if you're making the assumption that your patient's starting platelet count is at the low end of normal. So we are starting to see some clinical research showing that platelet-rich plasma can significantly improve our patients' outcomes and significantly minimize their pain and dysfunction when they have a diagnosis of rotator cuff tendinopathy. We are far enough along in the clinical literature that we can have meta-analyses, such as this one published in 2021. This meta-analysis looked at 8 separate randomized controlled trials, each of which was level 1 or 2. So there is literature out there supporting using platelet-rich plasma for rotator cuff tendinopathy. In 2018, this paper at the bottom of the screen was published looking at sodium hyaluronate combined with platelet-rich plasma for partial thickness rotator cuff tears. Although only some of the data was quantified, what these authors concluded was that PRP was better than sodium hyaluronate alone. So adding PRP to the injection for these patients gave them a better outcome that was durable out to 1 year. On the left, we have an article that was published in 2021 in the Journal of Arthroscopy. And you can see in the title here, they looked at subacromial platelet-rich plasma injections, and they found that they decreased pain and improved functional outcomes in patients with refractory rotator cuff tendinopathy. This protocol is interesting because the authors here in this paper got this result only doing subacromial injections. And I'm going to show you my current technique, which is quite a bit more than just doing a subacromial injection. But nonetheless, in this level 2 prospective study that was reasonably well powered with an N of 50, they showed that patients had 94% improvement in their pain scores and in their function by 6 months. 84% of the patients in this study returned to sports at the same level by 3 months, and only 7% of the patients required a second injection. And so this is one of the many clinical outcomes papers in the literature supporting using platelet-rich plasma for patients that have rotator cuff tendinopathy. And I think the other important thing to point out in this study is the dose. The platelet dose here was 5 billion. And so these authors got a fantastic result, at least fantastic result in my opinion, at a dose of 5 billion platelets per PRP injection. In summarizing the current best literature, platelet-rich plasma has the highest level of data currently, and the dosing for best results in multiple papers should be in the 5 billion range in a single injection, and that's based on the current human clinical evidence. So now let's talk about managing these same patients with rotator cuff tendinopathy, but let's talk about using a different orthobiologic, bone marrow concentrate. There isn't as much literature. Here's a study out of South Korea that was published in 2018, looking at the effects of bone marrow aspirate concentrate and PRP on partial tears of the rotator cuff tendon. What these authors found was that the addition of bone marrow concentrate to the injection gave patients better outcomes. There were some weaknesses in this study, however. The follow-up is relatively short at 3 months, and there weren't a lot of patients in this study. Each group only had 12 patients. But nonetheless, this was one of the early reports that even considered using bone marrow concentrate for this clinical diagnosis. Here's a 2020 study that was chaired or headlined by Dr. Chris Centeno and some of his colleagues at the RegenX network. And again, relatively low numbers of patients, but they did find that using bone marrow concentrate as one of the orthobiologics could give patients a 1-year benefit. So the DASH scores in this particular paper were better at up to 1 year. Important to note that in this publication, bone marrow concentrate was not the only orthobiologic. They also used platelet-rich plasma, and platelet lysate all in the same syringe. So this wasn't a pure study in terms of evaluating the outcomes just from a bone marrow concentrate injection. We do have some of that data. Some of that um, I have been able to quantify, and this is registry data. But in our study, we had 25 patients. We only used bone marrow aspirate concentrate, so there were no other biologics used. It was a single injection study. These patients were injected under ultrasound guidance, as shown here on the left. We had 2-year follow-up, and this is what we found. This chart on the right details the progression of pain scores. Before the procedure, our average patient's pain score was in the 6 range. At 6 weeks, it was a little bit less. By 3 months, the pain scores had essentially been cut in half. At 1 year, the pain scores were 1.7. And at 2 years, the pain scores were still 1.8, well below the initial pain score of 6 2 years prior to a single injection. And so our conclusion was that this orthobiologic intervention, bone marrow aspirate concentrate, is a great option to decrease pain. What doesn't show on this slide, but matches this chart, is that our patients' functional improvement matched the improvement in their pain scores. And so what I counsel patients that have these partial tears or rotator cuff tendinopathy is that this is a great choice for slowing tear progression, for minimizing pain over at least a couple years, and for giving them improved function without any restrictions for at least a couple years. I also make sure that our patients understand that not all of the patients in my study healed. We were able to say that the vast majority did not have any tear progression, but I don't want to do this procedure and have our patients think that this is a complete substitute for surgery because we weren't able to show that all of the tendons heal. Of course, for that matter, in surgery, not all the tendons heal either. So this is sometimes a good choice for patients that are looking for a non-surgical solution. Let's talk about adipose tissue. Now, in the United States, we cannot culture adipose. We have to use a version of adipose that we often call microfat, and it's either a centrifuged adipose or it's mechanically debrided, but we can't use enzyme to create stromal vascular fraction, and we cannot culture adipose in the United States currently. This 2018 study, which was also out of South Korea, was a cultured study. So I want to point that out for my colleagues that may see this talk that are in the United States. As of the time of this lecture, we cannot use this technique, but it is interesting to note that when these authors cultured up to 100 million cells and did a single dose intratendinous, that the defects decreased in size over 2 years. And in this study, it was a significant reduction in size, 83 to 90%. And so that's very interesting. That certainly merits additional study and additional evaluation of this orthobiologic. This may be one that we can one day tell people that if we use cultured adipose, we can actually get the same result as surgery. That would be fantastic if we could do that in the office. So just know that this is another orthobiologic that is currently certainly worthy of consideration and merits further evaluation. I would like to take a minute to talk about my current protocol for doing these injections. They are done under ultrasound guidance in the office. At this point, we are now doing 3 injections, and we do them in the following order. First, we inject the glenohumeral joint, and when I inject the glenohumeral joint, it's always from a posterior approach. Depending on the orthobiologic, we're injecting 5 to 6 cc's in the glenohumeral joint. One of the reasons we do this in patients with rotator cuff tendinopathy is simply because a lot of these partial tears start on the articular side. And in addition, a lot of these patients will have some component of glenohumeral joint, degenerative joint disease, and we can treat both of those quite easily with an intra-articular injection from a posterior approach. I then inject a small amount of orthobiologic intratendinous, and so this will be usually into the supraspinatus tendon. We are not trying to put 5 to 6 cc's into the tendon. This is usually a 1 to 2 cc injection. And then at the end of that intratendinous injection, as we back the needle out, often without making a separate entry into the subacromial space, we can then inject the subacromial space with an additional 5 to 6 cc's. We often do these injections in the lateral decubitus position because it's the most comfortable for the patient. It's very easy on the clinician as well. Here's an ultrasound image showing the posterior approach. It's an inline or in-plane injection. So there you can see the joint is right here. This is our target. Here's a needle coming in. In this example, we're going to inject a little bit of lidocaine into the infraspinatus and into the deltoid just to give a little bit of anesthesia. And then we're going to go in with our needle and go intra-articular, aiming right here where the blue dot is. And that's going to give us a good visualization of the joint. We can inject, we can watch as our injectate fills up the joint. After that, we do 1 to 2 cc's intratendinous, and we also still have to do some of the injectate into the subacromial space. The intratendinous injection I showed on the prior slide. And one of the technical pearls is after you do this injection, as you back the needle out, if you go slowly, you can get to this subacromial plane or subdeltoid plane and inject the rest of your orthobiologic without changing your needle. And so here's a clinical example of doing that. In this example, we're using a sagittal approach. You can see here, we're injecting the subdeltoid bursa right here. And you can imagine we could have easily taken the needle and gone into, for example, if this was tendinopathy, we could have injected this first and then just back the needle out and do our subacromial bursa injection on the way out. And so take-home points for treating rotator cuff tendinopathy. PRP, bone marrow aspirate concentrate, and adipose can all be effective therapies for symptomatic partial thickness rotator cuff tears. PRP at this point has the highest level clinical data currently, and the dosing for best results should be in the 5 billion plus range in a single injection based on the best current human clinical evidence. There's some evidence that bone marrow or cultured adipose may slow tear progression, but in my opinion, we need more outcome studies before we can have a definitive answer on that question. And so now I'm going to pivot. Now we're going to talk about augmenting surgical repairs. I'm going to go back to platelet-rich plasma as the orthobiologic, and we're going to talk about some of the research that's out there. The first point is there's a lot of clinical research on using PRP to augment rotator cuff repair. In 2023, this meta-analysis was published, and there are at least 16 level 1 studies out there. There's 9 other studies that aren't level 1. And when you look at those in this meta-analysis, the end conclusion is that using PRP at the time of surgery significantly lowers the re-tear rate of rotator cuff repair. And so that is something that I think is no longer controversial. I think that's something that has been shown in many different countries and many different studies by many different authors. And so that is one thing that I've talked to my patients about, that using platelet-rich plasma at the time of your rotator cuff repair, the most predictable outcome is that we're going to decrease the re-tear rate. Or another way to say the same thing, we're going to increase the healing rate. Using bone marrow concentrate has been shown to give an even better outcome than using platelet-rich plasma. In this study published in 2022, the lead authors looked at using PRP versus bone marrow concentrate versus just doing the rotator cuff repair. And when they reviewed this registry data, what they found was that patients that had bone marrow aspirate concentrate augmentation had 64% fewer revisions at 2 years. In this study, the PRP patients showed no significant difference in revisions. And one of the reasons I think there's differences in outcomes is because you have to look at the PRP dosing in some of these studies. So this may have been a registry review where the dosing was not even mentioned, or the dosing was below that 5 billion number that I think we need to reach clinically to get the best outcome. But here's an example where bone marrow aspirate concentrate has shown significant positive impacts on results for rotator cuff repair. This study by Brian Cole and some of his colleagues was published back in 2023. They used bone marrow aspirate concentrate. They quantified the mesenchymal stem cell dose at 25,000 and 2.7 cc's. Also important to note that they drew 60 cc's of marrow. And what they found in this study was that the bone marrow aspirate concentrate group showed improved tendon quality by MRI scan at 1 year. In addition, they found that the control group without the bone marrow aspirate concentrate augmentation showed greater re-tear rates at 1 year by MRI scan. So once again, BMAC led to significantly better clinical outcomes. And this is a procedure, an intervention that we can do in the office. It takes, or I'm sorry, in the operating room, and it takes, 15 to 20 minutes. This is the best paper published so far, looking at bone marrow aspirate concentrate at the time of rotator cuff repair. This was published now 10 years ago by Philippe Hernegal out of Paris, France. One of the things to point out in Dr. Hernegal's study is look how much bone marrow he drew. He drew 150 cc's. And so his dose was higher. His dose, if you want to consider the MSC count as a dose, was 51,000 MSCs and 12 cc's of BMC. The other really important thing that Dr. Hernegal quantified and that he details in his protocol is what he did with that injection. 2/3 of the injection was placed into the greater tuberosity. So if you're going to use bone marrow aspirate concentrate and you want to match his fantastic outcomes, then we should match his protocol, which means injecting 2/3 into the bone. Why does that make sense to me? Because that's where the mesenchymal stem cells live. And from that spot, they can help direct the healing cascade. 1/3 of the injectate was placed at the tendon bone interface where the supraspinatus was repaired. Using that protocol, what Dr. Hernegal found was that 100% of the tendons were healed at 6 months, 100%. And then here's the really interesting outcome. 10 years later, 1 decade later, 87% were still healed by MRI scan. That's a fantastic outcome, essentially unmatched in the rotator cuff literature. In the control group that did not have bone marrow aspirate concentrate, 67% were healed at 6 months, and at 10 years, only 44% were still healed by MRI scan. And so this is very compelling data to use bone marrow aspirate concentrate in this fashion to get this outcome. But remember, 150 cc's of bone marrow aspirate and 12 cc's of bone marrow aspirate concentrate, injecting 2/3 into the bone, 1/3 at the tendon interface. If you want to get this result, we have to start by matching his exact protocol. Here is an example of this exact technique surgically. And so this is a case that comes out of my operating room. And at the time, you were using a very small 2 mm punch to open up the greater tuberosity, and then we would inject our bone marrow aspirate concentrate down into the greater tuberosity. We have since discovered that you can very easily use an 18-gauge needle to do the same thing. The bone here is relatively soft. And so this is how we match Dr. Hernegal's technique. One of the interesting things you can do with biologics to augment your rotator cuff repair is if you're using a graft, and in this example, this is one of the newer strong implants called BioBrace. Not only is it strong enough to suture, but it's absorbable, which I like. So over the course of several years, this graft actually goes away. At the time of surgery, we can soak this graft with whatever biologic you'd like to use. We can use PRP, we can use bone marrow aspirate concentrate, and that gives us a really supercharged way to augment rotator cuff repair, not only with structural support, but also with a biologic augment. And so let's talk a little bit about adipose. There's not as much data using adipose to augment rotator cuff repair, but what we do see in 2022 in this paper is that patients that had augmentation with microfat did better on their functional outcome scores at 6 months, better than controls. And so this is some evidence that we should be considering microfat as a potential augmentation biologic for rotator cuff repair as well. And like a lot of our microfat literature, at least with surgical augmentation, we need more data to properly place this in our armamentarium. So the take-home points for surgical augmentation: do your biologic augmentation at the time of surgery. Bone marrow concentrate has the best reported long-term outcomes, better than PRP. There's more studies using PRP, however, and those studies do seem to suggest that using platelet-rich plasma at the time of rotator cuff repair can significantly decrease re-tears. We have to remember that dosing is important, though. And my recommendation based on the literature is to get our PRP dosing above 5 billion platelets, which most of the time means drawing at least 60 cc's of blood. Adipose may be a useful orthobiologic as well, but I think we would all agree that we need more studies to properly quantify the outcomes. So thank you very much for your attention. These are some of the other social media contact points for me.